Hyperkyphosis is often the root issue in neck, spinal, sacroiliac, and shoulder problems. Yet there is no real way to measure spinal curvature beyond an informal visual assessment. Every professional has learned to read the body for postural cues to some degree, but posture is extremely subjective and is usually hiding true bony alignment. By learning to utilize a few simple objective markers, you'll be able to uncover the true alignment buried beneath the surface and will better understand your client's pain continues despite ongoing treatment. I'd like to introduce our presenter, Katy Bowman. Katy is a biomechanical scientist focused on educating people on how their skeletal position and muscles affect various musculoskeletal alignments. She's the creator and talent behind the Alignment and Well DVD program and director of the Restorative Exercise Institute and the creator of Restorative Exercise DVD Kit. So I want to welcome Katy to the World Massage Conference. It's wonderful to have you here presenting with us today.
Thank you.
So, Katy, let's start. You can start with your first slide there.
Okay, my first slide, it's just a very simple kind of play on words. Aligned and Well is kind of the name of the larger chunk of information that we like to distribute. And obviously, all health professionals have had, some training in alignment. But what we like to really tease out is how critical alignment is to human performance, and then how alignment, when it's not where it's supposed to be, is really the largest mechanical contributor to disease, really across the board. So Aligned and Well, if you can kind of keep that in your head as something that anytime anyone has a problem, what we're looking for is the mechanical root cause. Where is the friction? Where is the misloading, overloading, underloading, pressure happening in the body, so that we can work to educate and work to provide, I guess, a platform or a series of treatments, or just even if it's just basic information about where to hold your body in a slightly different way, that really can help people work their way to kind of whole body, full wellness. So as we move on to the next slide, kyphosis is really a critical component, obviously, as you can imagine, to whole body alignment. And I'm going to define kyphosis just to make sure that we are all talking about the same thing, because kyphosis is one of those words, like many anatomical terms, that has originally meant one thing and has slowly began to imply different things. There are some assumptions that people make when you say kyphosis. There's the differentiation between hyperkyphosis and kyphosis. So I just want to make sure we're all on the same page. The type of kyphosis that we'll be talking about today would be kind of kyphosis in its most basic form. So kyphosis, most simplistically, is just an excessive forward displacement of the thoracic spine. Now, this can happen to a varying degree. So obviously there's mild kyphosis, and then there is, very significant kyphosis, and that's where the term hyperkyphosis came in, which means that there's obviously too much, but there hasn't been really for a long time any sort of quantification of what is too much. There's obviously we know what looks like too much, but we also know that there's supposed to be a certain amount of kyphosis to the spine, so there's this kind of general continuum, if you will. But the type of kyphosis that we're talking about is not major clinical, someone who can't stand up, that would fall under maybe some sort of other pathology or diagnosis, but the most common form, which would be postural kyphosis, which is something that you probably see all the time. And if you don't see it all the time, all you have to do is probably walk by your local high school if you want to see tons of it. You can see it everywhere. It used to be something that would kind of create an image of a senior population, but now with the age of computers and technology, and even I see it a lot in people who do a lot of body work because of the way We have to carry our bodies when we're working out in front of us or excessive driving. Everything has this element of forward displacement, and over time it takes its toll. And it's really the result, this postural kyphosis is a result of a poor muscular function that is a result itself of the way we use our body. So you will hear me interchangeably use kyphosis and hyperkyphosis because there's supposed to be a certain amount of kyphosis to the spine. Then technically hyperkyphosis is any more kyphosis than we want. But again, I'm going to be talking always about postural kyphosis and won't be working really in those major clinical issues where there might be an element of soft bone, etc. So if we go to the next slide from here, kyphosis obviously doesn't look good, but beyond aesthetics, kyphosis is actually its own independent risk factor in many other ailments, and obviously general back pain, both middle or lower back pain, sometimes even cervical back pain, kyphosis, depending on, I guess, the diagnosis of back pain. Kyphosis is a risk factor. Shoulder impingement syndrome, osteoporosis and osteopenia, any sort of bone loss. It used to be believed that kyphosis was, or that forward curvature to the spine was the result of osteoporosis, and now it's known that is, in fact, the risk factor for osteoporosis, which also leads itself to future spinal fractures, especially in the mid-back, impaired pulmonary or breathing function, which then, of course, has its counterpart in compromised cardiovascular function because of the way the inflation of the lungs affects the rate of the heart, and then impaired digestion, all that forward pressure and the way that we cope with it and how it changes the pressures within the abdomen. It affects normal biological function happening in the abdomen. And then overall decreased physical functionality, meaning the ability for one to have a high level of self-efficacy, especially in aging populations. Kyphosis is the risk factor. So we need to kind of step in and understand now that a kyphotic curve or excessive kyphosis now is really a risk factor for bigger things later on. It's as much as it seems like it's good posture versus bad posture or something that we want to change the look, we're really talking about kind of an early red flag about whole body health as we age. So as a health practitioner, it's really nice to be able to have a discussion with someone or to be able to help correlate a situation that they might have with kyphosis. If, in fact, they realize they have kyphosis, if, in fact, you realize they have kyphosis, which is what this, of course, is all about. So we go on to the next slide where we have this kind of a basic picture of a, quote, normal spine. And I use quotes a lot kind of to tease out, it's not really a sarcastic thing, but normal amounts of lordosis, kyphosis throughout the spine are taught. We're taught that there are these normal amounts. And so you kind of get this anatomical picture, and you know that there's supposed to be a certain amount of cervical and lumbar lordosis and a certain amount of thoracic kyphosis. But because there is such wide anatomical variation amongst the human population, there isn't a absolute value of curvature that one is supposed to have. So it's not like you can learn clinically that someone should have a 30-degree curve here or a 15-degree curve here, etc., because the amount of curvature you have is based on your anthropometric dimensions. So it's based upon the girth and the weight of your bony segments, because the greater or the less those values would be, the greater or the less force dampening your body would need. But when there is not a absolute value for each person, it still doesn't mean that there's not a normal. It just makes it a little bit more difficult to teach someone how to screen for what normal is. So the normal that you're going to learn today would be the normal that is what we consider an alignment marker, and I'll move on to that in just a second. But it's the amount of curvature that loads the discs the most correctly, in that it doesn't place any excessive force in order to get the job done, so your degenerative forces are low while your muscular performance is high, which is really kind of the baseline for skeletal normal in the body just in general. So if we go on to the next slide, we're going to talk a little bit about the difference between alignment and posture, because I teach kind of the physics of alignment. I like to introduce kind of the differentiation between these two terms, and it's going to be really important when it comes time to do an assessment that you have kind of a way to tell all the difference. So this is just kind of a picture, and we'll work with this picture, this image right here, so you're looking at both an alignment and a posture. But we'll move on to the next slide, where we just have a kind of a quick definition of each of these terms. So the first being posture. Posture means a position of the body. That's all it means. So every type of activity has a posture. The posture that we refer to when we refer to something like a postural screening would be usually accepted as most general kind of upright posture, your standing posture. If you're doing it in a gait clinic, sometimes we'll do a walking posture, but usually it's standing posture that is taught for body reading courses, etc. But it means a position of the body, as opposed to alignment, where alignment means how the parts of the body are arranged so that they are able to do their performance in a maximal way. So the arrangements of parts so that they're in their correct relative position. So it's very specific. It has to do with how every joint in this machine is articulating. And we'll talk about cars in a second. You have kind of a general sense of what your car or wheel alignment should be. And that's why they use that term, because when the alignment of the car is off, the function of the car is low. Now, the difference between these two things, if we move on to the next slide, is, in a nutshell, posture is a very subjective thing, meaning it can be kind of open to interpretation, whereas alignment would be objective. So if we go kind of like through a list of what makes good posture, they tend to be agreed upon parameters, which is what makes this kind of a challenging concept to teach sometimes. Because posture is it's a cultural phenomenon. It's these parameters that a group of people, which is it's in itself the definition really of a culture, that they've defined the values, what's valuable and what's not valuable. And when you've taken your academic or your anatomical training, a lot of times within the context of a culture, like we all have, then a lot of these cultural memes, which are kind of a meme is just kind of a message that's passed on over and over again, we don't always get to the scientific bottom of what is a valid component to the orientation of the physical skeleton and which isn't a valid one for alignment purposes. It could be absolutely valid for postural purposes. So I made a kind of just an easy list, and you could probably add 2 or 3 that you've been given in a lifetime of those general, quote, good posture guidelines: shoulders back, chest up, heads up, keep that stomach in, keep that bottom tight or tucked, depending on if you're a man or a woman. Keep your knees soft, put your heels together, and you might not have even heard all of these on this list, but someone has kind of within this culture. And a lot of these postural guidelines, I guess if you will, have made their way into clinical assessments. And so what happens is it makes the data that you're collecting when you do a visual assessment or a body reading session, it means that you're kind of comparing what the person is presenting with maybe not the right alignment points. So if we go on to the next slide, we'll talk a little bit about alignment and what makes a good alignment parameter. And so the parameters, or the way that alignment parameters are decided upon or are created, would be that these are the parameters that, if they are not in this way, would have a negative impact on the function of the body, some function of the body. So if we look at all the things that the body is supposed to do, and we were kind of looking at systems, you would look at the reproductive system and the neurological system and the digestive system and the circulatory system, the musculoskeletal system, and you could come up with a list of how all the different variations of, I guess, alignment, the way the segments were related to each other, how that would impact these systems, either for the good or for the bad. And then you just keep evaluating that system until you find an alignment that is, in fact, a neutral, meaning that it's kind of that physiological homeostasis. So with biology, biology never really works with too much or too little. There's kind of a neutral with everything, and we understand that when we talk about the environment and trying to manage wildlife or temperature, that it's a very delicate system. And if we kind of take that larger understanding of the natural world, environmental science, biology, and apply that same thing to the ecosystem that is yourself, it's pretty easy to find those neutral points if you know the physics of the body, because at the end, the main thing that the body is doing is cellular regeneration. And so any sort of alignment that reduces cellular regeneration by either reducing the delivery of oxygen to the tissues or by increasing the pressure to the tissues, which increases inflammation, which then starts a degeneration process. So anything that slows down or causes slows down the regeneration of cells, causes the cells to die at an excessive rate, or kind of impedes or makes the cellular reproduction process even slower or more slow than it should be, would be not the correct alignment. So we have these points that we use that are very objective, meaning that when you learn to use these points, you'll know that you are working more in an alignment realm than a postural realm. They're based on geometry. They're based on physical, or the laws of physics, I guess, if you will, and they're cultural free. So there's not an element of, well, this population has been doing it for a long period of time, or anything like that. There's no cultural context. It's not a set of points that was designed for a certain practice or for a certain group of people who are all doing a certain thing or who are all at a certain size. It really is just about human body function. So if we go to the next page, when you have a system that teaches alignment points, and that these alignment points are the same for every human body, more or less, it's kind of a challenge, because as trained professionals, most of you know that there's a very wide spectrum of anatomical variability. So when people have unique shapes or sizes, how could it be that there are certain parameters of the body that would be the same for everyone? And you just always need to kind of go back to that basic understanding that most of us have, which is where there is wide anatomical variability, mechanical laws don't fluctuate, meaning that gravity doesn't affect you different, relatively speaking, than someone else because of your shape and size. So when you learn the mechanical laws, which is what biomechanics is the Newtonian physics applied to the biological process. These laws don't depend on the size and shape of the body. So it's a really nice, simple way. It almost seems so simple, almost seems too simple, but you can really take a nice reading of what's happening to someone in the way that they're moving, that kind of highlights for that person why they're having so much trouble with their body, when in those early stages of having trouble, so much of what you come back with from, maybe more of a clinical assessment or an allopathic or medical assessment is, well, there's nothing really wrong with you yet. I mean, you've obviously got some signs of inflammation or some signs of friction, but there's no injury or disease yet. But if you know how to take a good alignment reading, then you will see what is going to be in the body, which I, of course, still find fascinating even after all these years. So moving on to the next slide, the big question is, how can someone hide kyphosis? And that's going to be the next few slides that we're going to do from this point are all going to be looking at some images of someone kind of before and after we put them into more of a reading with more alignment specificity, I guess, if you will. Because it seems like kyphosis is this big, huge curve to the body. Kypho itself is the Greek word for hunchback or stooping or bent forward. So if you have kyphosis, I know it seems like if you've got it, you've got it. Why can't we see it? It's an anterior displacement of the spine. Your head should be out in front of your body. There should be something, and there is. But the human body is also very clever. So if we go on to the next page, I'm going to have you look at your client here. So the big question is, when you are looking for kyphosis, whether you're working with a client population or you're just checking people out, at the gym or when you're walking around, you have to always ask yourself, are you assessing alignment or are you assessing posture? So I created this slide as kind of a test that you don't have to turn in, don't worry, for yourself to just with a quick using your eye, because that's what we use most of the time. We use kind of our vision against a set of information that we have in our mind. And we're doing this all the time. I think kind of as biological creatures, we're always checking out other biological creatures for who knows for what, for lots of good reasons, I'm sure. But when you're a clinician or when you work in health and alignment, you're probably drawn to looking at how people move, how people stand, how people carry their body just in general, and probably are jumping to conclusions via your training, which is fine. It's great. That's really what training is all about, is to get really good at seeing a situation, cutting down a client's time, knowing how to take a quick reading and then get in and do some sort of treatment or movement prescription or whatever it is that you're doing with this information. So if you just had a pen, or even if you just want to keep a mental note and you made 2 or 3 general decisions about this person's kyphosis, then I want you to keep those in your mind just kind of as a reference for at the end of this presentation. You can see how maybe your jumping to conclusions has improved or not. And we'll go to the next slide. So I put a picture of the human skeleton-ish, kind of, with this same body, because the set of parameters that you are likely evaluating someone on is this anatomical neutral that we've all learned, in an anatomy or physiology course or an alignment or a posture course at some point. So you understand by looking at the skeletal picture on the right that this is what is neutral. Most people actually have a pretty good sense of anatomical neutral in a picture form. Seeing where the skeleton is in someone, as in the client picture to the left of the skeleton, is a little bit more tricky because you're looking at skeletal bones on the right, and when you get to the left, our eye is a lot of times distracted by I call them like the false curves to the body, and they're true curves to the body, but they're false curves to the skeleton. So if I took a pen, which I'm actually doing right now, and traced alongside the skeleton, I can get a pretty neutral curve, the same curve on both pictures. They look very similar. Now, obviously, the person has clothes on, but we tend to read the flesh. We tend to read the adipose and the muscle curvature more than the bones, because even though you've learned your skeletal alignment, your skeletal anatomy, your muscular anatomy is spot on, we need some sort of GPS when we're looking at somebody to know if what we're looking at is actually where we think it is. And so that's why all of our alignment points are bony landmarks. We don't use any sort of soft tissue. So now that you've got the skeleton here, you're still kind of maybe making some assessments about what's happening to your client. And we'll move on to the next slide. And so the next slide is looking at your client actually in anatomical neutral that was featured in this previous slide. So as you were looking at that skeleton, you knew that the hip and the knee and the ankle should all fall in a plumb line. But in the person standing there, that wasn't happening yet. So what's happened in this picture is this client has been made to look more like the skeleton, starting at the feet, and we back the knee and we back the hip marker that you will learn in the follow-up video until those are stacked vertically. So the kind of graphic chart on the left is actually from our alignment course. So points 6, 7, and 8 would all fall vertically over each other. And then the next piece is, in order to assess spinal curvature, you have to, I always say neutralize, because that's how I like to think about it, but I think neutralize might be something else if you're a Star Wars fan or have some sort of neutralizing gun. So you need to normalize or neutralize or find neutral pelvis. There we go. You're going to find a neutral pelvis first, because the pelvis is the platform for the spine. And if the pelvis is not sitting in neutral, it means that the curve reading that you're taking, although it might look a certain way, if you had a normal or, quote, neutral spine sitting on top of a non-neutral pelvis, it means that you can't possibly have a neutral spine. Some part of the spine has to be an excessive amount of flexion, probably around the lumbar area, in order to be able to achieve that look or that appearance. So you start with the feet, you align the legs, you align the pelvis to neutral, and then there's one more point, probably the most important point, and that's point number 13. So you can see 11 and 12 point on the left are the ASIS and the pubic symphysis. So the ASIS and the pubic symphysis, there's two ASIS. All three of those points should all fall in a vertical plane. They're always stacked above they're always in line with each other by the nature of the way the pelvis, the bony pelvis is, but we want that plane that they're in to be completely vertical or aligning in the frontal plane. So you have 6, 7, 8, 11, and 12 all in alignment. And then there comes the point of the bottom ribs. And the bottom ribs are probably going to be your biggest indicator that someone is hiding a kyphosis. And you'll be able to see a nice demonstration of this in the video. So don't worry if watching kind of or looking at something on a two-dimensional sheet doesn't make super sense now. It will when you see the actual body doing the motion. But in order to assess the spinal curvature, you have to stabilize, or you have to control for, find zero before you measure, for all the parts that the spine is attaching to. So if those ribs are out in front of the body, it means that the thoracic spine is also displaced anteriorly. So you do a kind of a combination of lowering and moving back, moving posterior the rib cage until the bottom rib, that lowest bony rib protrusion, comes into that frontal plane as well, so that it itself is lining up directly over the ASIS and the pubic symphysis. When you have those points, then you can see if your client can move their ear, which is point number 10, without going into hyperextension, if they can actually extend their thoracic spine to come back into that full 6, 7, 8, 9, 10 alignment marker or postural guideline that most of us know, right? The ear, shoulder, hip, knee, ankle. The body is really clever about getting those points in alignment, that kind of main line, by displacing lots of other joints, meaning that you can pull your shoulder blades together. This client could pull their shoulder blades together in order to move the shoulder back, but the spine, it doesn't do anything about the thoracic spine, and in fact, it's kind of our cultural guideline of keeping your shoulders back that's really contributed to allowing the thoracic spine to collapse forward, in addition to lots of other things, meaning that pulling your shoulder blades together is not the correction for excessive flexion to the thoracic spine. So only when I have the ankle, knee, the hip, the ribs, the pelvis in alignment can I then assess that this client does not have the ability at this time to articulate and extend his thoracic spine. Now, in order for me to be able to see that, I had to make sure I was assessing his alignment, meaning I had to set all his points equal to that skeletal reference guide that I'm using. There's no point in using a skeletal reference guide that has all these fixed points if we don't, in fact, have our clients move into as many of those anatomical zeros as possible before taking an assessment. And so if you go to the next slide, this is the posture. This is your client's posture. So some very common kyphosis hiding tricks are basically all the things that we had to correct for before taking a reading. So there's that anterior displaced pelvis is very common. It's common in most people all of the time, probably a lifetime of wearing a shoe with a positive heel is a main contributor. The pelvis is, pelvic thrust is probably the easiest way to say it, but there's a displacement of the pelvis. The hip marker on the side is no longer vertically aligned with the knee and the ankle and is out in front of the body, which of course means that if you have an anterior displaced pelvis, you also have a non-vertical leg, which means your skeleton is not bearing the weight of your body, which of course is important with the process of osteogenesis, right? This person here, in his posture, his hips are less weight-bearing than if he actually had a neutral alignment. So that position of the hip relative to the ankle is in fact what determines your weight-bearing status. And if you have a chronic pelvic thruster, you'll have patellas that don't relax, meaning that the quadriceps are not able to relax or drop. They just stay in their upward contraction all the time. You have a shelf sternum, a sternum that is not, for all intents and purposes, vertically aligned, but maybe projects forward at an angle. And then, of course, the easiest to spot marker is the protrusion of the rib. So if you take your own hands and you reach down and feel just below your chest, and you just kind of keep moving down your rib cage, if you can feel that bony prominence, then there is more, we call it ramping up, dropping down, forward, and sliding back to be done in order to have a neutral rib cage in the same way that we have a neutral pelvis. So if we go on to the next page, probably the most important concept to understand is the difference between vertebral extension and vertebral shear. So now we have these two bodies side by side, and I labeled them A and B as a position. So when you see someone who's standing like A, who actually had many alignment markers going for him, he didn't have all of them because he's physically unable to do it right now, as opposed to B, where he had 0 alignment markers in line, but probably appeared to be much more in alignment. When we see someone change from A to B, let's say you have a teenage kid and you see him sitting like A, and you say, hey, pull your shoulders back and lift your chest up, and now they're B. The belief is that someone just went from the top A to B, which is kind of my interpretation, my loosely inspired graphic interpretation of kind of a hyperflexion to a less flexion, meaning that the traditional understanding of a person when they shift from these two postures is that they extended their spine from hyperkyphosis to a normal amount of kyphosis. But what's actually happening, if you go down to the lower A to B, is that that curve is not changing because those vertebrae are not articulating. They're unable to extend. But a habit, a lifetime of doing this kind of masking of a hyperkyphosis causes someone to shear forward. So shear, I put those 2 arrows so you know it's a planar motion that is not extension because it has an element of posterior rotation with some elation, meaning that one vertebral body is just sliding forward on top of the other. Obviously, that's a very damaging thing to do to the vertebrae themselves, not to mention the discs and the nerves and the actual spinal cord itself. But this is what most people are doing. Most people are taking their hyperkyphotic curve, doing a single vertebral extension with a combination of really extension and shear while everything else continues to stay in flexion. And that's where the ribs forward are coming from, is from that shearing motion. So it's just nice to kind of get a picture of the physical difference. And, of course, we don't learn vertebral shear in your anatomical class because it's not a healthy or a natural vertebral motion. The ligaments aren't able to withstand it for a very long period of time. So it's something slightly different. Obviously, we learn it a lot in biomechanics because it's what injuries are made of, but all is not always what it appears when someone, quote, straightens up their spine a little bit. Now, why is this all important? If you go to the next slide, is because by putting someone in alignment and realizing that someone actually is masking hyperkyphosis, what you are going to help someone realize is that their root issue, that person who was doing the shear and the extension, is likely going to have lots of spinal issues, breathing issues, digestive issues. There can be, everything, foot, knee, hip, pelvic issues. But the real problem is they are not going to walk around looking forward at the ground. And some people have, 45 or 50 degrees of hyperkyphosis to their spine that they are masking and still are walking around, quote, upright, but fully displacing all of the cavities of the body, all of the soft tissues and bones of the body, all because of this root issue of their thoracic spine does not extend through its normal range of motion. And you can't fix it until you, 1, can recognize that it's there, but 2, learn how to stabilize the rest of your body. You can go lay over a bolster or do some sort of exercise, but most people, because they don't realize that they have hyperkyphosis, will take all of their same postural crutches with them into the corrective exercise arena, and they won't make as much progress as maybe some of the efforts that they're putting into. So if we go on to the next picture. Kyphosis isn't pretty, as we said in the beginning, but there's a very high cost of hiding kyphosis, and this is just kind of a quick, really oversimplified, but not necessarily. It's just simple, I guess I should say, of how the orientation of the body needs to change. It's very subtle. When you take 20 degrees of a forward displacement or a forward rotation of spine and have to correct it, you don't do all 20 degrees in one place. And I'm just making up a number here, but you do a little bit here, a little bit there. So this person who walks around in, quote, maybe the okay posture that you thought at the beginning is in cervical hyperextension. So, again, this is risk factors for headaches and thyroid issues, snoring, sleep apnea, respiratory, breathing, TMJ, foggy brain, all those types of things that, kind of come with that area. Big risk factor for osteoporosis, mid-back pain, stabbing pain underneath the shoulder blades, again, breathing and cardiovascular issues. Because of the shear and excessive compression in the back, spinal disc issues, SI joint issues, general low back pain, specific low back pain. And then there is that way that the pressure is changed within all three of the cavities because they're always affecting each other. But a big risk factor for diastasis recti, digestion, chronic core musculature that just is not innervating or protecting the lower back because, of course, you have to have a neutral spine in order to have full use of your TVA, which, of course, is required for full stability of the discs in your spine. Pelvic floor issues, you can just keep going on, but all of this is really the root cause for so much degeneration in the body because, again, we're masking really only one area of the body that is unable to articulate well, and that is the thoracic spine. So you've got, it's expensive. It's an expensive habit to want to hide your posture, but then there's also the cost of the actual kyphosis, which is what happens to vertebrae and muscles and a nervous system in an area of the body that has no articulation is, of course, has its own pathology that come with that. So we'll move on to the next slide, and it's just a chance to take, I guess, any questions that you might have on this presentation.
Katy, thank you so much. That was a really nice, detailed sort of A to Z way of looking at that. And I haven't really heard a lot of sort of those comparisons of the difference between alignment and posture. That's something that's kind of new in one presentation that I've seen.
Oh, well, that's great. And that's, I think that it probably depends on what field you're coming from beforehand. Posture is the way something looks. In a nutshell, posture is the way something looks. Alignment is the way something works. And I think alignment is a new word that people are using because, we're talking about how, to move bones and where tissue should be, and all that's great. It's just always remembering that there should be a baseline of rationale that's underneath the alignment points that you're learning or you're teaching to make sure that it's always a situation that is not interfering with the biological process. So sometimes just a semantic clarification helps with, I guess, even just general alignment studies in general, just having that notion of, like, am I evaluating this based on, what I think looks good because of the culture that I belong to, and, how much of your mother and your grandmother or your religious school teacher is coming into or participating in your evaluation that you don't even realize because it's been, quote, the good posture information that you've been given your whole entire life. So that's why I like to clarify between the two.
Yeah, and that makes a lot of sense. And you mentioned a comment about, typically we think about older people, that are maybe a little bit more hunched over. And with all of the things that we do, like the amount of time that we spend on a computer now, because when we were kids, we would spend all day at school, but when we would go home, we wouldn't be on computers all day, and we wouldn't even be reading, at the books all night. We'd be out playing a lot with a little bit of homework. And now these kids are, in school all day. They come home and they're on the computer all night, and that's the same with people working as well. We're sitting a lot more. So if you and I are in offices next to each other, we didn't have instant message and we didn't really, use email. We actually got up and, moved to each other's offices. So even in the workplace, people were walking around a lot more.
Oh, yeah, and the pathology, clinically speaking, the pathology that we're finding in people who are in high school, at that age, really between 16 and 25, is freakishly similar to people that we used to see between the ages of 65 and 85. So as I like to say, 20 is the new 80 in terms of bone density. There's juvenile osteoporosis that's happening, the muscle atrophy or wasting already that's on this population is real similar to people who are, done with their manual labor, and everyone used to garden, and everyone used to be so much more outside, and TV did not used to go on, beyond 9 o'clock at night. There's just so many factors, and obviously we teach natural movement, so the changeover for humans from hunter-gatherers to people who are more farming populations or pastoral people, and then of course you have the Industrial Revolution, and then now we have the technological age, and each one of these are benchmarks not in our favor, really, of health. So finding or restoring kind of your natural alignment so that you're not impeding on your physical function is really, what they're calling for in the literature as like the last hope. There's no more, we have to go back to moving more, following nature's rules of moving that. Maintaining the physical body.
Makes a lot of sense. I'm going to bring in Cliff Korn. He's been taking questions from our listeners on the live presentation. Cliff.
Yeah. Thank
Hi,
you. How you doing, Katy? We have really some interesting questions here. But I'm going to start with one of my own, just because I can do that.
You get to.
I have tons of clients of my own who I try to deal with what I'd always called postural issues, but I will now call alignment issues. But one thing that I'm still missing a little bit that would help me a lot is where's the actual research that we can go to find out how we can define what actually correct is. What's the specifics of this as opposed to the generality?
Well, pretty specific. I mean, most of what I teach is based on my thesis work in biomechanics. Unfortunately, the reason I went into doing what I do is, as a mechanical engineer, you learn how to build something like a robot for the purpose of it. You're considering your materials, you're considering alignment components that increase or decrease wear and tear, and it's not written in one place. I mean, I think one of the biggest misnomers is people think that with research comes a wide distribution of, now that we know that, this is the correct place, we'll make sure that everyone gets the memo on it. So when I was in graduate school, I was like, what if we put out or created some sort of guidelines for human machine operation that would help people, because there's no manual for the human machine and how it's supposed to be articulating. That all being said, the way that the alignment points that we use in our curriculum come from is they're generated from, thousands of articles. So most people understand that the osteogenesis cycle, or the process that generates bone, for example, is a weight-bearing process. It's a mechanical signal. But the distribution of information gets kind of modeled if people don't actually know what the term weight means. So you might have heard that you need to be weight-bearing in order to build bone, and that's all, clinically researched. But then how does that get dispensed to health professionals? Is like we need to start using weights and increase the loading of our body in that way. But that's not what it means at all. It means that the bones, the weight-bearing bones in your body, need to be as vertical as possible to fall in line with the gravitational force, which is a normal or a perpendicular force. So anytime you're pelvis is not stacked vertically over your ankle, you are going to be less weight-bearing, whether it's out in front of you or back behind. So our guidelines, our alignment points are all based on mechanical, mathematical arguments like that, because there is no single source where someone has looked at that, because, of course, it's extremely expensive, and there's not like clinical trial that you can do. You just have to assemble lots and lots and lots of other people's work who are looking at smaller points like that, I guess, if it makes sense. Like the leverage, how does the leverage system work? And it's when you know lever systems and you know how to calculate them, it starts to make a lot more sense to go, oh, I understand that a little bit more. But it's really, it's kind of, when you don't have a mechanical comprehension, or it's not comprehension, because I think that we actually are pretty mechanical, but we don't have training of how to apply those basic lever systems. Like, when you walk up to a door in your house, if you want to open it, you don't pull on a handle that's only 2 inches from the hinges. You're going to put the handle as far away from the hinges as possible to get as much leverage. Mm-hmm. And the whole body is arranged like that. So when you understand how to calculate the leverage system, then you can kind of get a better sense of where everything is supposed to be for the purpose of aligning the fibers of the muscle system. Each fiber plane of a muscle dictates its force generation capability. The resting length of a sarcomere generates its force capability. So we look at how changing the skeletal position, you can't really, what changes the length of your sarcomeres, which is really what drives all of the force generation process in the body, is dependent on where their skeletal attachments are. So your habitual postures, which are the positions you take in your body, they are displacing your muscular attachment points and putting them into an area that kind of promotes the words that we tend to use kind of in a non-physical science training would be like, you're impeding the flow of your body. We understand what that means. You're impeding your circulation. But what it means from an electricity argument is that you changed the sarcomere where it can no longer conduct electricity. And if you can't conduct electricity, you can't innervate those tissues, you can't vasodilate those arterioles, and then you can't pull blood from the main arteries into the capillaries, which is, of course, is the thing that drives tissue feeding. Tissue feeding, like the whole reason you move, the reason you need to move, is because without it, your tissues die very quickly because they eat oxygen. Oxygen needs to come out of your arteries and into the capillaries, and the way it does that is through muscular contraction. What drives muscular contraction is skeletal position, and what affects skeletal position is your posture and your postural habits and how far it is away from alignment.
Well, then I'm guessing from your answer then that there's probably not a lot of information if we check osteopenia and spinal alignment and PubMed. We're not going to come up with 30 or 40 different
points. No.
Abstracts.
Yeah, that was a long answer to say no.
Gotcha.
It's like it seems like all the major human things that we do, which is, mate and have kids and use our bodies, there seems to be absolutely no data to help us out to do that whatsoever.
Right. Well, and if we're supposed to get the bones, vertical for gravity, I guess we should be standing our tables up on ends, but
yeah, well, stand. I mean, that's why sitting is the new smoking. Now they realize you got to stand as much as possible and walk.
Here's a question from one of our listeners tonight. If a client is really out of alignment and we want to help them get back into alignment, where's the best place to start? Do we start feet and work up? Do we start mid-body and work up and down? If the pelvis is the key to this,
you want to start at the feet. Yeah, the feet is where you start because it's the skeleton is displaced by where you spend your body, but also the forces that you create when you move. So I just got done. I'm actually currently on book tour for a foot book because you can't even be in a neutral alignment if you have shoes on, if you have a positive heeled shoe on, you automatically are no longer vertical. You have to flex your knees, you have to tuck your pelvis. So the way the foot interacts with the ground would be your starting point. And then, of course, the next level is, well, what about the tissues in the lower leg? Because every tissue is passing over a leverage system. So when you have an area of musculature that doesn't lay at the right length, then it has to bend or defer a joint a little bit so that it buys itself a little extra length, and then hence you kind of get a collapse. So most of your forces affect your thoracic spine, and that can really help contribute to that forward curvature is the tension you have in your lower leg, that tension mostly coming from the habit of wearing a positive heeled shoe throughout a lifetime. So if you start with the feet, you can, one, really help someone find a neutral, which in the video will show you can actually follow along, and align yourself with that next 30-minute clip. And then that way you're not trying to adjust a vase or arrange a vase of flowers sitting on top of a crooked table, right? You're trying to change the way the forces you're trying to change the forces that are created by your gait pattern, essentially, so that they don't kind of whiplash your spine. Because your head is the farthest thing away from the ground, it's the most susceptible to angular acceleration. So this, like when water comes towards the beach, it's all moving at the same rate, but as the shore comes down into the ocean, there's less space for the water, so that's what makes a wave. The upper water starts going faster than the lower water because the lower water is experiencing more traction. That upper water arches over, and that angular acceleration process of water is the same thing that happens when your lower leg is really tight. It actually is moving slower than the upper segments of your spine. So one of the root things for kyphosis that we would teach is leg and lots of calf stretching would be that initial place. People find a lot of relief from headaches from stretching your calves because you're just changing the way every step affects your vertebrae.
Okay, I'm getting a little breaking up here. Maybe it's just me. I'm going to press on here.
Yeah, you're good now.
Okay. Is the answer to corrective actions more orthotic in nature or changing muscle memory for structural alignment, or both?
Well, an orthotic is not a body strengthening device. I mean, you can get an angle to change with orthotics for sure, but in the same way that you can you can set your elbow flexion based on a sling, changing the joint while simultaneously weakening the structure is not what we're after. What we're after is restoring the conduction of electricity back through the muscular system so that it has the ability to provide the constant circulation to the body, but also so that all the tissues that are connecting to it are allowed to do what they're supposed to do. So I would say that no, you're trying to retrain someone, and I use the term retrain loosely because for most of us it's not a movement pattern that we've lost, it's a movement pattern that we've never had. So it's much more about learning, perhaps maybe for the first time, how to articulate different segments of your body in a unique way, because we have a pretty small amount of movements that we share as a culture. The culture, Western culture, all about the world, high-stress culture, highly sedentary culture, have really a lot of the same what they call affluent ailments that are alignment or mechanically based. But yeah, the goal is to get the body to do it itself.
Well, that's kind of the perfect segue. There's, let's see, 3 questions here that are very similar. Going from what we're trying to do, but these are basically, all right, now how do we make that happen? What techniques do you suggest non-Walters use to correct kyphosis? What do you suggest for treatment? Bottom line, how do you recommend that hyperkyphosis be treated by massage therapy? Or where can we find more information on that? So there's a number of questions here on, they love the assessment piece of that and everything, but now what do we do with it once we see it?
Right. Well, I would strongly encourage everyone to visit the trade booth, or they can go to the Institute site, because there's a lot of, you can take, we have a full body alignment course, but you don't have to go, quite that far yet. The mobilization and stabilization are the two things that the human body needs. It's just knowing what needs to be mobilized and what needs to be stabilized against some sort of alignment points to kind of discern from each one of your people. As people who are doing more of a manual therapy, I would assume most of the people who are listening to this now, spending time with the root issue, for sure, helping people mobilize an area of their thoracic spine is obviously going to be critically important. But your patterns of posture are reinforced by the way that you move all of the time. So if someone, even if someone comes every single day for an hour, and if you have someone that comes every single day for an hour, please give them my number so I can figure out what they do, or they can come every single day for an hour for manual therapy, which I would love, and I did it for a week, and it was the best thing I ever did in my entire life. The problem is with our mind. I mean, really, the motor programs that you have are contained in your mind, and they're just reinforced throughout the day. So through our website, you can access, there's thousands of hours, because there's hundreds of articles, and there's lots of free material and videos online where you can start getting a better sense of the corrective exercise solutions that you can offer your patients. But it really, at this point, comes down to education. It's about having a dual role as, yes, you are a clinician, a hands-on practitioner, but what might be even more important, and which could have even a greater impact on your practice, is how well you help people change the way that they move, and then, of course, something as simple as the way their office is set up, how much they sit, the way that they sit. We have videos on how to make over your car for better alignment. How do you change your office so that this person doesn't always present with the same issue every single time they see you? And, of course, most clients, when they come, it's like they have the same problem all the time. It's like, well, the real thing I can offer you as your part of your healthcare team is to help highlight areas that are keeping you in this cycle of pain and give you some things to try at home. But, when you have that word exercise, people are like, well, I don't want to do exercise, and some people do. But it's more about footwear, understanding how your client's footwear is affecting their back pain. That's huge. If you can help them understand that, because no one really minds changing a pair of shoes, because it's just a matter of how I change my footwear in the morning. It's like the most low energy thing I could possibly do and still have a great impact. So we have lots of different solutions like that online, and there's hundreds of them. You just have to take a little bit of time to start reading, and I'm happy to direct people in the Q&A afterwards to maybe more specific posts for their specific questions. But whole body alignment is a big science. It's a big field. There's a lot to learn, but when you do, it's just like a whole door opens to you and all the clients that you see, because you really do have a bigger toolbox for helping.
All right. Well, we're getting down to just the last couple of questions that have been turned in here. And other than the person you just mentioned who comes daily, one question here is, how often should we see a client to make the most effective, long-lasting changes in their posture? And I guess the corollary to this is, about how long would it take to bring someone back to a more normal or desired alignment?
The how long question. I always like the how long question. I teach there's an online podcast that everyone can listen to, but basically the 10,000 hour rule for learning something in your brain, because your motor programs, they're coming from your brain. They're stored in your brain. So it's about breaking old motor programs and having new ones available is the key. But 10,000 hours is the point at which it really becomes kind of second nature. So if you're doing something 3 times a week, 3 hours a week, trying to learn a new skill, which alignment is, because it's how you are carrying your body relative to other body parts throughout the day, 3 hours a week will take you 27 years. So we suggest that people kind of have in their mind more of what we call the 3-year program, which is 8 hours a day. And again, it's 8 hours a day not of doing something necessarily, but it's 8 hours a day of really having awareness to where your body is. And again, we suggest that everyone start with footwear, understanding how their footwear is affecting their alignment. Then we go to sitting habits, reducing the quantity that you're sitting by 10%, so just creating, a simple standing workstation is definitely great. And then, of course, there are corrective exercises that should be run through, some are like 15 minutes a day. And then you're thinking about your gait pattern. When you stand, you're not, if you were the client in the video, you're not pushing your pelvis out in front of you and lifting your chest, but you're backing your hips up and dropping your ribs. Every time you do that or make a correction when you're standing in line, at the bank, at the grocery store, those are all kind of going into your alignment bank account. And so if you can be aware of your body for 8 hours a day, which of course is what we're all trying to teach people to do, but you have some sort of checklist instead of, just check in with your body isn't for a lot of people enough to help them start reducing their alignment-based ailments. So it's more like, I want you to check in with your pelvis and where it is relative to your heels, and you're going to do that every single time that you're standing in line or up and walking. And if you give someone real specific parameters like that, they'll notice improvement right away, significant improvement in things that have bothered them for quite some time. And if they're doing it in conjunction with body work, once a week or whatever, obviously the more is always better, but whatever someone can fit into their life plan, the better results they will have, the faster their progress will be.
All right. And Mel, I'm assuming we have some time for this. I have like 2 more questions here.
Actually, Cliff, we're cutting it pretty close. Do you have one more question there?
Yeah, there's one here that's just so practical it's scary. Does a big belly make it harder to determine hidden kyphosis?
No, because you're not looking at the belly. You're not looking at the belly. The bony markers that we use they're usable in every population, and it's a nice one because I'm actually 7 months pregnant, and I'm on the video, and so you'll be able to see what we tend to use. We're so kind of caught up with looking at the curvature of the abdomen on the front and then just kind of imposing that, well, that must mean that the lumbar spine is curved, also into hyperextension, and that's not the case. Most people are in flexion of the lumbar spine, and that curve that you see that looks like a lordosis curve is created by that shearing forward that you're seeing. So many people are being misdiagnosed as hyperlordotic and being told to slightly tuck their pelvis, when in fact their pelvis is already tilted posteriorly, their lumbar spine is in flexion, and they've got this shear component. So you don't read any sort of soft curve. It doesn't matter how much extra mass or weight you have on your frame. Your pubic symphysis and your ASIS are still palpable because luckily those aren't adipose dropping sites. So that's what makes bony alignment points so nice, is it doesn't matter if you're 140 months pregnant like myself or if you have 100 extra pounds, you can still help someone. You can still absolutely help someone.
Outstanding. Katy, thank you so much for answering the questions. This is one of the best things I've been part of in a long time, and I'm certainly going to be looking for some different things than I have, and I've been practicing for quite a while. So thank you much. And Mel, it's all yours.
Great stuff. Thank you, Cliff, and thanks to everyone who was submitting questions on the live presentation. And if you're still hanging out on the live presentation, Katy will be jumping in the chat room after, so you will get the opportunity to to chat with her. Katy, is there anything that you wanted to say to just wrap up here?
I would just like to say a huge, tremendous thank you for everyone who's ever gone into the art and science of helping others. I just don't think that this group of people is appreciated well enough for their intention. And if I can do anything to help disseminate a tool that will help someone manifest their intention into even greater reality, then that's what I'm here for. That is my sole purpose.
Hi, I'm Katy Bowman, and welcome to the Restorative Exercise Institute. Today we're going to talk a little bit about how to take all that information that you just learned in the course Hidden Kyphosis and apply it to your everyday client to practitioner scenario. You just learned a lot of clinical definitions of extension, inflection, hyperextension, shear, how all those things relate to each other, but it's not really super helpful when it comes to that one-on-one interaction. So I'm going to walk you today through kind of the standardized way that you can very quickly take an accurate, objective measurement of the alignment that your client has, rather than that kind of real subjective, like, well, it looks like kyphosis or it looks like hyperlordosis. There's a way to actually tell. So I'm going to show it to you in practice because it makes it a lot easier to see in video format. Also, you can really get a better understanding of what we mean when we're talking about spinal extension versus a single or two vertebral extending just on their own, vertebral bodies extending on their own. Now, because human bodies vary so much anatomically in terms of their anthropometric dimensions, there's not really a correct quantity, absolute quantity of lumbar or thoracic curve. So when we say someone has hyperkyphosis or hyperlordosis, there needs to be something that we're comparing it to, kind of a zero or a neutral per person, in order to really accurately say one way or the other and make sure that the correctives we're giving, if we are giving any, are the appropriate correctives for that person's their true alignment, as opposed to the posture that they're presenting in. One of the ways that clinically people are measured for kyphosis and lordosis is using a flexible ruler such as this. And so the theory behind using a flexible ruler is that you mold the flexible ruler to the contours of the spine, making sure that you start at, there's objective markers that you use from C7 down to S1. It's not really anything that we use, but for our intents and purposes today, what you do is when you pull it away, you trace on a graph paper, you can then measure the quantity or the area that would be underneath the lumbar and the kyphotic curves, and you can compare that to a population to see if one would fall into a category of hyperkyphosis. The problem is there's no standardized way of taking this measurement, meaning when I measure on a skeleton, the skeleton is fixed into its anatomical neutral, or how we understand anatomical neutral to be. So I know for sure that the vertebral bodies are positioned in a specific way. But what you're going to see here today is how to tell if someone is standing with one or two vertebral bodies in extension, how that will give you one particular curve that when you put them against a zero or a foundational neutral, that you can see what their curve actually is. Because bones can move away from the skin. They can rotate slightly, which would keep them against the surface, but which would take a lot of their musculature with them. And that's really important to understand therapeutically, because there's a lot of issues that go on with thoracic vertebral bodies that don't articulate, because it means all that musculature that's connecting to that area that depends on those bones for particular leverage or geometry for particular leverage is unable to work. And it might help explain certain issues of the spine, certain issues of the chest, certain issues of anything really in the lumbar area, the thoracic spine. So maybe it could be a whole body masking issue. So I'm going to take someone right now, and I'm going to show you, one, how your clients are presenting themselves when they come in, some kind of standardized method for setting them up against an anatomical neutral, getting them as close to anatomical neutral as you can, using a very few simple and easy to use markers and tools, nothing expensive, nothing really challenging to add to your current practice, but how you can not only see yourself, but probably more importantly, show them the parts of their bodies that are articulating and the parts of their bodies that are not articulating. So again, a lot of people are told that they have hyperlordosis because of certain presentations of not their skeleton, but really their more soft form. And I'm pregnant right now, so if I turn and you see an excessive amount of belly or roundness here, a lot of times we're measuring lumbar curve based on the contour that we perceive is here. We kind of project that this contour here must be created by some sort of bony deformation here. But that's actually not the case. And we want to get away from evaluating people based on soft tissue. Looking at adipose, looking at muscle is not a good way to see what the skeleton is doing underneath. For a couple of reasons. One, because there's no objectivity there. But two, those soft tissues are not the anchorage for the leverage system of your body. And we tend to learn anatomy based on attachment points, but we don't really consider where those attachment points are relative to each other. For example, you might learn that your deltoid muscle is kind of cupping the shoulder in a real simple kind of example. But if someone is internally rotated, their deltoid is now moved to the front of their shoulder, and unless you have some sort of objective way to measure where all those attachment points are, and you use it every single time you need to do an evaluation, you're going to be kind of projecting this anatomical zero onto a person who is not in anatomical zero. So we have to put them in anatomical zero before we make any sort of assessments and telling them what muscles are longer than or shorter than their optimal contracting range. So let's get started. So this client walks into your studio and you're going to do an assessment. So if you just take a minute to look at the frame that's in front of you, you can kind of come to maybe some quick conclusions using whatever template you have in your mind for assessing posture or alignment or however you think about it. And while you're doing that, I'm going to take the traditionally used spinal curvature measurement. And this measurement, this technique, it's used as an evidence-based technique, meaning that it's shown enough similarity, practitioners can use it to really see if someone has hyperkyphosis or not. So I'm going to pull away, and you can see what the general curve is. So this looks like a very normal spinal curvature. There's no evidence of hyperkyphosis here. But remember, this course is called hidden kyphosis. This course is about what our postural habits mask for a long period of time. Michael here is in his mid-30s. We don't normally see hyperkyphosis in such a young population because, as we'll see, there's a lot of kind of coping mechanisms or postural mechanisms that we use to mask it. So I'm going to leave this curvature here so you can see again, I just placed it along the spine starting at C7, went down right to the S1, pushed into the spine and forced it and changed position, and using the evidence-based method, there's no standardization for data acquisition, meaning you just go ahead and tell someone to stand in their best posture. Are you standing in your best posture?
I am now. Okay,
now he's standing in his best posture. I'll take a second measurement. And I pull this away. And you can see that there's some kyphosis, there's about a normal amount of kyphosis, amount of normal lordosis, certainly nothing that rings any flags as being particularly great. And I'm going to set this down. And then we're going to come back, and then I'm going to show you a technique that puts Michael in a neutral position. Because right now I'm evaluating where Michael is relative to the ground, really as opposed to where Michael's bones are relative to each other. And I want to be able to see what's mobile and what isn't, because that's really important when it comes to joint and muscle health. Is, are the muscles or the soft connective tissues impeding on a joint's ability to articulate? Because if you have a joint in the body, it should be articulating. That's what the joint is for. So if you start looking all the way down to the ground, we always start our basic alignment from the ground up, because the forces that are generated or placed upon the body happen when the body interacts with the ground reaction force. So I want to kind of see what that looks like. And right off the bat, I'm going to pull his pants a little tighter so you can see. This is a plumb line. This is actually just any regular exercise tubing. You can use anything that you already have. It just needs to be free hanging, meaning it can't touch the floor. It needs to kind of hang from your hand. So if I hang this at the midpoint of the bony pelvis, so the way you're going to find that point that you line up with is not using the racing stripes on track pants. You're going to find the skeletal front and back of the pelvis, and then you're going to bisect that, or find a halfway point between the front and the back. And I'm going to go all the way out from the soft flesh, because we don't add soft flesh into our skeletal assessment because it's non-contributory to kind of our data at this point. So you're going to go ahead and find that front and back point, and then you're going to find the midpoint, and that's where I'm hanging it from. Now, usually racing stripes will line up on it a little bit, or the seam of the pants, but you can see that, I'm going to pull this away a little bit, that his pelvis is slightly out in front of the ankle joint. Now I need the midpoint, which I'll call the hip, to line up with the knee, to line up with the ankle, so that all three of these points are vertical, or are plumb. So I'm going to have you back your pelvis up until I get these points in a vertical line. And now I'm going to pull his pants up here. So the way that you find the midpoint of the knee and the ankle is the same way. You find the front and the back bony boundary and you bisect it. So let's go ahead and call this the side point, about halfway point. And the lateral malleoli of the ankle is a real simple kind of alignment point for the ankle. So I'm going to pull, and you're so great, thank you for backing up all the way, and back until those points are stacked vertically. That's good right there. Now I'm going to hold this line here. Hopefully it'll stop swinging here in a second. And I'm going to have Michael go back into his old standing position with his lower body. So go ahead and go back to your best posture. So you can see the quantitative difference between Michael's best posture and a neutral alignment. That's really required for the skeleton to be weight-bearing. Everyone's heard of weight-bearing bone. That's what that means. So right now, Michael's hips are less weight-bearing than they would be when he backed up. And that would be if his torso was able to come with him. But as you saw, when you backed your pelvis up, go ahead and back your pelvis up until you find that vertical alignment. Now we're starting to see a different spinal presentation. A lot of times your clients, when they come into a neutral leg, will have to compensate with forward flexion. Not contained within this course, but certainly within our full alignment courses, is what this means about the hip flexors and the psoas muscle when the torso is unable to right itself or be normal, which means neutral or at 90 degrees vertical, on top of a normal or neutral leg. So being able to measure someone's alignment versus their posture really clues you into things that you might have missed in terms of tension, things you might have felt manually when you're working on someone, but maybe is more difficult to convey or explain when you put someone in front of a mirror. So I've got Michael here in a neutral leg. Now it's not enough to be in a neutral leg. You have to go to neutralize, which I don't know if that's the right term, the next piece, and that's going to be the pelvis, because you can have someone on a vertical leg who brings their torso upright by tucking their pelvis under. So I want you to posteriorly tilt. So you're going to tuck your pelvis. Now I don't want someone to be able to do this because now this moves the pelvic floor slightly out in front of someone. So there's also a neutral pelvis. The neutral markers for a pelvis are the ASIS, so anterior superior iliac spine, over the pubic symphysis in a vertical plane. So this is a really nice technique that will help take kind of the guesswork out of when someone should tuck and when someone should untuck. Because a lot of times when we talk about using that front round belly look on someone as a guesstimator of where their pelvis was, it's not really the case. In pregnancy, obviously, you know that the abdominal wall can displace quite a bit, and it has nothing to do with where the bony pelvis or the spine is. It has to do with what is happening within the abdomen, in this case, mass-wise, but also in other cases, there's a lot of other things that can affect the volume of the abdominal cavity that isn't related to the skeleton. So a tuck in this case, or in that case, would still not be the right prescription. So we're going to back Michael up into a vertical leg, and then we're going to go to the vertical pelvis. Now, I always suggest that you teach someone else, teach the person that you're measuring these points, so that you don't have to put your hands all over their pelvis, and then it gives them a skill set to be able to use later on. So I'm going to have Michael put his hands on his ASIS. Thumbs work best, and then you can probably fold, unless you have really short fingers, your middle fingers to find your pubic symphysis. Now, you as a practitioner can evaluate vertical, but if you have a mirror, it works really well to teach someone how to evaluate it themselves so that they can tell whether or not they're tucking anteriorly or posteriorly, and to show them how they should be in neutral. But keeping in mind that neutral pelvis isn't really neutral unless it's sitting on a neutral leg. So you have to get the neutral leg first. So you're in neutral?
Yeah.
I would untuck just a little bit, right about there.
Okay.
And I'm looking at his middle finger points and where they fall, making sure that they fall below. So we've got a neutral pelvis, neutral leg. And you can hold that there? Feel comfortable there?
Yeah, can I move my hand?
You can move your hand. Yeah, you can let your hands relax down by your side. So now the spinal situation is starting to change again. So let's say we only taught someone this point down. And I think a lot of times people learn that neutral line, the shoulder, the hip, knee, and the ankle line. But here's the thing. I can have a completely vertical lower body, and I can bring this shoulder joint, the glenohumeral joint, into alignment. So if you kept all of this from the waist down vertical, and I told you that correct or good posture was pulling the glenohumeral joint into alignment with this, could you do that?
Yeah.
And you can see that what people do is they extend, not their entire spine, as you'll learn, but they're extending at one point to be able to make this marker. So if you're just using one plumb line, it's really incomplete, because what most people do, and what Michael's doing right now, is he's taken the curve of his spine and he's simply kind of put it back on its end, or kind of rolled it back a little bit, which would displace the bottom part of the curvature, which are those lowest ribs, out in front of the body. So let's take a look. I'm going to find my trusty plumb line again, and I'm going to have you reach your arms out in front of me, just to get them out of the way. This doesn't really do anything structurally, it just keeps the arms from being in the way. And if I find the bottom of his bony ribs, and you can kind of put your fingers around to the point in which you feel the last rib, you kind of loop your finger around it. You shouldn't be able to, but it's a good way to feel where that lowest rib point is. And you hang a plumb line from it, you will see that the rib cage is now displaced out in front of the rest of the body. So that's your objective marker to know that the vertebrae are not in neutral. You've got some extension at some points, which is different than spinal extension, because he didn't extend his entire spine. He really just sheared forward at one vertebra, kind of a combination of extension and shear. So, in order to really take an accurate measurement of what his thoracic spine is doing, he's going to have to bring the bottom rib on the right and the left side into the same plane as the ASIS and the pubic symphysis, because that's our anatomical neutral. The same goes for the ribs. The ribs have to be part of that line because the way the anatomy and all the attachment points of the core musculature work geometrically in terms of force production depends on kind of a neutral pelvis being directly below a neutral rib cage. It's kind of like if you imagine two rings stacked above each other. If you have any sort of pitch change to either one of those, you're not going to be able to maximize the force production of the trunk, which is, super important. So I'm going to have Michael make a correction. The correction is not just flexion, meaning I don't want him to lean forward. Because he's done a combination of extension and shear, the correction has to be the opposite of both of those planes of motion. So there needs to be a certain amount of forward rotation, but there also needs to be an element of backwards or posterior translation. We call this ramping up at the Institute. So you're going to drop your ribs, but you're also going to back up until we get the line of the bottom rib to come in right over the ASIS. This is a lot of work, and it's also, surprisingly, the position that we use to work our abdominals, where if you just had your ribs in neutral all the time, your abdominals would be firing all the time. It's when you go back and stand up into your normal posture, go ahead and let your ribs go back up, then you turn off kind of that core musculature. So you're going to back your hips up, and you're going to bring your ribs down. Now we've got neutral. Now, Michael, believe it or not, is actually neutral. If I was able to cut off his body at this point, he would look like someone who was standing really vertical. But what are we left with? We're left with where his spine actually is relative to all of the other parts. So here was his measurement before. You can see that he had, a relatively normal amount of thoracic kyphosis and lordosis. But now when I take a second measurement, we're going to see that his amount of kyphosis, we'll start at C7, is actually much greater. There's an element of kyphosis that's been here the entire time that Michael masks, like most of us, with a very subtle forward displacement of the pelvis and kind of opposite of ramping up, a extension and shear of the ribcage. So this is his posture. His posture doesn't look so bad if you're just kind of comparing it to what you think good posture should be. But if we actually take an anatomical measurement against a baseline, which makes it much more subjective and makes the data much more accurate, we find that his alignment is actually a lot more like this, meaning that he doesn't have a problem articulating in certain areas, but these vertebrae themselves are not extending. He's extending these vertebrae here. So you can go ahead and stand back up so people can see the difference. So you don't want to take your measurement in someone's best posture because it doesn't really tell you anything concrete. You need to find a baseline, and eventually your clients get better at moving into a baseline. And here's the thing, standing in anatomical neutral is the way that your body is able to generate the most force production out of your musculature system and do the least amount of damage. It's also, on a bigger plane, a lot of disease that we have is made from not operating in neutral, but operating in these areas. He's got a lot of compression in through the spine here. In some of your clients, sometimes you'll find people who go all the way forward to get their ribs down, and their amount of hyperkyphosis is so great, but they're not walking around like that. So when they stand up, you know that their rib cage has sheared so far forward that it's now operating at an angle, which of course is going to affect the way the lungs deploy, the quantity of oxygen that's getting into the body. So it seems like anatomically, what's the big deal if someone's alignment is different than their posture? It's a big, huge deal. It's a machine. It's designed to manufacture cells, and the rate of those cell manufacturing depends on its alignment, because that's what alignment means. Alignment is the position that parts need to be relative to each other to get the maximum amount of production, longevity, oxygen distribution, life, essentially, all those things. I wanted to give you kind of a real close-up experience of the difference between spinal extension and vertebral extension, and how those two different situations can change the presentation of the spine, but in different ways. So I kind of created a little bit of a hyperkyphosis. So theoretically, if you're looking at a spine that has this quantity of thoracic hyperkyphosis, and someone were to extend their spine, that extension is happening at every vertebra at a relative quantity that ends up changing the curvature. So it would look something more like lots of different segments doing their own little bit of extension that reduces the curve. That's what spinal extension is. It's the sum total of what many smaller parts are doing. So I'm going to put this back into this kyphosis. What we're doing, we, you, me, most people that you will see, is not thoracic extension throughout the spine. But what Michael was doing, and what, again, most of your clients are doing, and what you're probably doing, is it's taking this curve, and this curve, you can see how forward this curve is projecting. This would be where the nose is pointing, so we're working in this plane of motion. Is extending at one area as well as translating or moving forward. So I'll show you what that looks like mechanically. It means that not only is there this backward motion, but there's also a forward displacement. So you can see the net effect is taking that curve and just displacing it relative to the ground, which is how we tend to assess people. We look at how they are presenting to the ground. And if you kind of pan out and you look at this curve here between the shoulder blades, theoretically, and the ground, this looks like a nice minimal curve. But the problem is the way that he got his body into this position has kind of like a ka-chunk. And that's not a clinical term, but it's just like a big old crazy mangled spot of alignment in order to present as if he wasn't someone who had this thoracic alignment, which he is. So we have these spots in our spine in which the vertebral body is loaded in an abnormal fashion, both in terms of the bone itself. The bone itself is now under compressive forces that shouldn't be there. But the ligament system is also being strained, and ligaments don't have the ability to respond the same way that muscles do. So you can only do this so many times to your connective tissue before the elastic or the collagen in the tissues permanently stretch out. And using up your collagen in this format is very similar to using up the elastic in your socks. Once you've used that elastic, there's no more structural integrity to that collagen, which is fine because you have the muscular system, but you'll create a situation of disease right about this area of instability. It could be degenerative disc disease, it can be a slip disc, it can be so many different things. But also, it neglects the fact that there's not any articulation up in this area, which also has its own health consequences. Showing them how to stand in a more of an anatomical neutral by backing their pelvis up, which of course you can't do when you wear heeled shoes. So both of your assessment and then of course your everyday living should be done without that positive heeled shoe, because there's no way to assess someone if they have an actual 20, 30, 40, or heaven forbid, more than that lift underneath their heel. But also that their muscles are able to kind of find neutral, which does take a period of time. So standing with their pelvis kind of backed up in that way that I moved my client here, but then also having someone learn how to drop their rib cage, which at first feels very sloppy. It feels like you're leaning forward, but you're not. It's really more of a sensory thing. If you've been walking around in extension and shear, when you come out of it into something that is neutral, it's going to create the effect, that corrective distance that you close, that forward and that downward motion. Although it is neutral, better for the body, better for the muscle system, it's going to kind of play with your mind or the user's mind in making them feel that they're much more sloppy. And of course, that's one of the reasons that we stand up and really back in the first place, is because there's an element of perception there to what is good and what is bad. So I like to teach other people how to use the mirror so that they can see that by pulling themselves into anatomical neutral, or really relaxing themselves into anatomical neutral, they're going to be hitting the objectives that are probably in their top 5 reasons that they're seeing you therapeutically. Is to get out of pain, to be in better health, to be in better shape. All of those things will be improved by a simple pelvis and rib adjustment. Then, of course, the next thing therapeutically is to work at mobilizing some of those thoracic spine, and then that's a whole other amount of correctives you can bring to someone. And then that general understanding, if you are prescribing different stretches or different poses, that people be aware of where their ribs are when they're doing those correctives. Because if you go to stretch your chest or your pectoralis or whatever you're giving someone to stretch, and the ribs are coming up with you, then they're going back into their old habits and they're not fixing their body relative to the change that you'd like them to make. So with just a little bit of information, they can go a whole lot farther in terms of their goals that they either are sharing with you or maybe just have on their own personal list. Thank you so much for joining me. I look forward to a relationship with you and teaching others health through alignment, objectivity, and learning how the human machine works for the longest amount of time, pain and disease free.